So we're here to talk, of course, about mantle cell lymphoma. Now, of course, in many respects, I always think of this as a disease that has the worst of all aspects, the more aggressive behavior than follicular lymphoma and the less good response rate than diffuse large B-cell lymphoma, raising challenges in terms of managing the disease. So what for you have been the highlights in terms of mantle cell lymphoma at this ASH meeting?
Yeah, I think I agree that it used to be the disease with the worst prognosis among the lymphoma, but the
things
time
are
is
improving.
Changing.
Yes,
time is changing, especially in the first-line treatment. So it's very exciting data which combine the rituximab and Revlimid, lenalidomide in the first-line treatment. But definitely the relapsed refractory patients, lymphoma patients, have a still not very good outcome. So there is a very great need of the unmet medical need. And there is some data in terms of the new agent, there's a lenalidomide. There is some data how to manage the patient who failed this treatment or who failed the ibrutinib. So, and this is the field we have to improve.
Now, of course, we've got a much larger number of agents approved in this disease than we've had before, bortezomib, lenalidomide, ibrutinib now also. How do you think about how having access to these more novel agents, when we do, is going to change the way you think about the management of relapsed and refractory mantle cell lymphoma?
Yeah, definitely. For the patients who relapse or who are refractory, these new drugs will be definitely the choice of the next treatment. Until now, we have a data in this subgroup of patients as a monotherapy. The future probably will be the combination of the several agents or combination, the antibodies and these targeted treatments. So definitely it's going to change the landscape, how we can manage these patients.
Of course, in mantle cell lymphoma, as we have in other diseases, you now have an era where, on the one hand, we're talking about, for younger, fitter patients up front, very aggressive chemotherapy regimens, including transplant, and at the same time bringing in novel agents, these so-called kind of chemo-free regimens. Where do you think we are in this disease in terms of what the role of chemotherapy is now, and what you think the role of chemotherapy-based regimens will be several years from now?
It's a very good question, and the answer is not so easy. But I think that for a while we still have to use the chemotherapy. So, and especially we have to use the chemotherapy in the clever way. But there is a subgroup of patients with a high MAP, young patient, who still behave poorly in spite of they are treated with the chemotherapy or immunochemotherapy. So the addition of the drugs, like the ibrutinib or the change of the anti-CD20 antibody, can improve the outcome of these patients. And it will be tested in the next generation of the European mantle cell lymphoma studies.